And I've been asked to speak on one of the main works that's been happening across the palliative care world in Ireland with culminating in the publication of a palliative care competence framework in November of last year. And whilst this day is really about assessment, we assess based on what we do as part of a curriculum, and this framework is designed to assist with the design, redevelopment and development of curricula for health and social care professionals to ensure their competence to provide palliative care irrespective of the level at which they're working or the level of interaction with patients, service users and clients who are and need palliative care at any particular level, which I'll talk about. So the background itself, as you know, most of the areas of health have a national clinical programme, as does palliative care. And part of their key work objectives for 2012 was the establishment and design of a palliative care competence framework. What was interesting was it took 10 years for this to actually happen, because it was a recommendation from the National Advisory Committee on Palliative Care report in 2001, which was adopted at that time by Minister Martin as Minister for Health as policy for palliative care in Ireland, and remains to this date the policy driver for palliative care. And when that was published, there was a key recommendation about identifying and developing core competences for all health and social care professionals delivering palliative care at whatever level that was being delivered. So the overall aim was to develop this competence framework for health and social care professionals. With palliative care, as you all may be aware, palliative care is really about interdisciplinary and multidisciplinary working. And this task of developing the competence framework fulfilled that remit also, with partners from the Health Service Executive itself, the National Clinical Programme for Palliative Care, the Office of the Nursing Midwifery Service Director, my own institute, the All Ireland Institute of Hospice and Palliative Care, the Irish Association for Palliative Care, which was represented by Professor Philip Larkin of this school, who's the clinical chair in palliative care, who was the chair of the IAPC at the time, and the Irish Hospice Foundation. I'll just leave that slide for a couple of minutes, just to show the diversity of those who are on the steering group, representing colleagues from across the various health and social care professions. It was chaired by Dr. Karen Ryan, who was the then clinical lead for palliative care. Karen's term ended at the end of last year, and we're awaiting the appointment of her replacement. We did this work based on the most up-to-date definition of palliative care, which comes to us from the World Health Organization 2002, which defines palliative care as an approach that improves quality of life for individuals and, importantly, their families who face the problem associated with life-threatening illness. One of the things that, just to point out, is that we do not use the term life-threatening illness from the Republic of Ireland context of palliative care. It was felt by the National Clinical Programme for Palliative Care that threatening was in itself a word that had really negative connotations. So we tend to use the term life-limiting condition as opposed to life-threatening illness. That varies for children. We still use the term life-threatening illness when it comes to children, and these are described as illnesses that have the potential for cure, with the life-limiting condition are those illnesses that do not have the potential for cure. And the key elements of palliative care are there for you to look at. It's around pain and symptom management, affirming life regarding death as a normal process. We always refer back to Ben Franklin, who said the only two certainties we have in life is death and taxes. We are all going to die. And while end of life is a part of palliative care, my job is also to dispel the myth that it is only about end of life care. Palliative care, as the WHO says, can be provided in conjunction with other therapies which are there to extend and improve quality of life, those including chemotherapy and radiotherapy. And interestingly, what the WHO is saying is that if we introduce palliative care early in chronic illness, it has massive positive effects, both in reduction in comorbidities and extending life and mortality rate, but also reducing the significant burden on quality of life. A huge study by Jane Temmel and colleagues in the US, which was published in the New England Journal of Medicine in 2010, identified in one particular population group, massive population of those diagnosed with small cell CA of the lung, that if they were referred to palliative care early, 75% reduction in comorbidities and 60% extension in mortality, with a significant improvement in quality of life. that has influenced referral rates for people with small cell CA in this country, with consultants from our oncology colleagues who were reluctant to introduce palliative care now referring much earlier, which is a really positive outcome. We talk about palliative care as being both generalist and specialist. It can be provided in all care settings, including community, nursing home, hospital and specialist palliative care units. The scope in recent years has broadened so that palliative care is now provided at an earlier stage in the trajectory of both malignant, which it has always been synonymous with, and non-malignant disease. And what we see now is that rather than having 100% referral from malignant disease, what we see is that we're moving towards currently about 70-30 split, 70% of referrals to specialist palliative care coming from those who have the diagnosis of malignancy, while 30% are coming from chronic illnesses, the most being the degenerative neurological conditions, particularly from MND. But we're also seeing people with end-stage chronic renal failure, end-stage COPD and end-stage chronic heart disease being referred for complex symptom management, but also being referred early, which again is a very positive. The levels of specialisation within palliative care are identified in the National Advisory Commission on Palliative Care, and this influenced our development of the competence framework. So for level 1 it was the palliative care approach, which all of us as health and social care professionals should be aiming to work from. General palliative care is a more intermediate level, where it's for those who have greater interaction with patients, clients and service users who are further along their journey, needing more palliative intervention, and those professionals providing this level of palliative care would have completed some additional education to enable them to provide from a higher level of competence. And then level 3 is specialist palliative care, and this is where the only job of these individuals is provision of specialist palliative care, either as nurse specialists working in hospitals, community nurses working in the home, providing specialist palliative care and support, or working in an inpatient unit. We used Bloom to underpin the taxonomy of the competence assessment, and we did take into account the incremental nature of knowledge attainment for the skills that we really wanted people to attain, and it was based on their experience and their clinical interaction, but also on their education achievement. And really it was around how do we actually try to define what competence is in the context of palliative care. And Bob Becker, who's done a huge amount in this area prior to his retirement from his job in the UK, he really did say there was a lack of consensus. So we had to address that. And we addressed that by doing a scoping exercise, which I led from the Institute with my colleague Karen Charnley, who's my programme manager. And we looked at what were the other frameworks out there from the UK, the US, Canada, Australia, and from Northern Ireland. Northern Ireland are in the happy position of having their strategy for adult palliative care, and they're much younger than ours. It was published in late 2010. And at the time then groups were set up to develop education, etc. And they developed a palliative care assessment tool. And based on their experience, we didn't use that model because it became a self-assessment and didn't actually articulate with anything to do with curricular development, assessment and design. So what we did was we looked differently, and we said, and I insisted that at all of the specialist discipline working groups, there had to be statutory and regulatory body involvement. And from a nursing perspective, Judith Foley, who's one of the education officers within the NMBI, sat on the working group for the nursing, midwifery discipline and healthcare assistants. So we identified six domains. Domain 1 being the principles of palliative care, which underpin what we do around the totality of the individual, not just their physical symptoms, but their psychological, social, spiritual and emotional well-being. Communication is central to what we do in palliative care, given that we are dealing with people who have complex needs and also their families who are going through traumatic events. Rather than just focusing on symptomatology, it was around optimising comfort and quality of life. Recognising the interdisciplinarity of palliative care, it was around care planning and collaborative practice. We experience loss, grief and bereavement at many stages in our life, not just when we're diagnosed with a life-limiting condition, so that was important. And also recognising that all the professions we were working with have ethical codes of conduct, and it was how do they relate to palliative care. Each domain is defined, and those competencies that are core reflected right throughout each individual's specific discipline. Just to move on, there are 3 levels that we've identified which reflect the levels of specialisation, level 1, 2 and 3. So the all health and social care professionals, the sum are those who are providing a greater level of palliative care, and the few, which is those of us who are specialists in palliative care. So what are the implications? For us, the palliative care competence framework is providing for core competences for all health and social care professionals, 12 in total that we've focused on, detailing discipline-specific competences up to specialist level. We hope that it will inform academic curricula and professional development. It also will enhance the care of people with life-limiting illness and foster greater interprofessional and inter-organisational collaboration in palliative care provision and indeed in education. The outcome is a very clear, I believe, competence framework that is there for us to use. From a nursing and midwifery perspective, it identifies the competences from core right up to specialists at all divisions of the register, including midwifery. And looking at the last draft of the NMBI Standards and Requirements for Nurse Education and doing a word search on palliative and end-of-life care, it's actually verbatim lifted from the competence framework, what is required for our students going forward when we are actually looking at our curricula. It was launched by Minister Lynch on the 4th of November last. It's available to download in its entirety. It runs to 192 pages, but there is a specific section for each discipline which runs to about 35 pages that can be downloaded, and the web addresses are there and they can be circulated afterwards. Thanks a million for your attention.